So, welcome back, everyone. We are going to continue practicing. And we started already with the steps of the protocol. Who already practiced from the team? Okay, so we can carry on with others and we go through the protocol while we do it together. And who would like to do next? Perfect, so go for it. So thank you, Veet, for helping us. So we are going to start from the IVC, the gateway of the protocol, mid-axillary line. This is a curvilinear transducer. The indicator will be towards the patient's head, and then put the probe perpendicularly on the abdomen. See the liver, so slide downward towards the feet of the patient until you see the liver. So now you can clearly see the liver. Maybe we can turn the light off. It will get better image of the screen. You will see the liver, and sorry, we'll leave it. Then we will try to avoid the lungs by moving the liver in the middle. So slide downward towards his feet until you get the liver in the middle of the screen. So slide down anteriorly a bit. Yeah. Yes, very good. So you can see here, I think you're further down because you started to see the kidney. So go upward a bit upward. And that's the diaphragm, that's the liver. And then you need to do a bit of tilting to get the inferior vena cava. So try to slide up first and then do tilting the tail down gently, tilting the tail down until you see the IVC. Tilting the tail down, and that is the inferior vena cava here. This is the IVC. Can you see it? And that is the hepatic vein draining into the IVC. The hepatic vein has a classic anechoic hole. So adjusting the depth, the hepatic vein has an anechoic hole. And to confirm that, put color Doppler, the flow is blue because it's moving away from the transducer, right? And then to confirm that it's the hepatic vein after color Doppler, put pulsed wave Doppler. And then we will maybe try to move it into the main vein. And then you will see that antegrade flow. It's not actually monophasic. The monophasic is because we are not in the main trunk of the hepatic vein. So we'll try to optimize the image so we can get the true pulsatility of the hepatic vein. Okay. Get 2D again. Do a bit of tilting. Tilting the tail up. Yeah, you got it. Yeah, stay there. Very good. Okay. You're moving. Let me just a little bit guide you towards getting the best hepatic vein trace. So do you see that? If you hold the probe and just keep it there, do you see that hepatic vein there? I will try to put the pulsed wave sample volume in the middle of the vein. And even if you don't see the clear triphasic pattern of the hepatic vein, the main idea is to see the antegrade flow, the flow below the baseline. Because the flow in the hepatic vein normally should be moving from the hepatic vein to the IVC during most of the cardiac cycle. The only time where the hepatic vein flow move retrograde above the baseline is during atrial contraction, as we discussed in the beginning. Do you see any retrograde flow? There's no significant reversibility, so that is normal. Even if you don't see the classic triphasic pattern of the hepatic vein, the one you see there on the screen. So that is normal, and it's a real life situation because sometimes you can't get the proper tracing of the hepatic vein, meaning the S and D, but it is clearly antegrade. It's below the baseline. And then I would like to try to optimize it a bit. I mean, you already got the portal vein. So do you see, let's do the portal vein because you already got it by tilting the tail of the probe down. And I knew it's the portal vein because the wall is hyperechogenic. And when I put color Doppler, it is red. And red because the blood is moving toward the transducer. And if I put pulsed wave, that is the typical monophasic pattern of the portal vein. Your hand moved. That's okay. Just stay there. Stay there. I'm going to put it here. That is the typical monophasic pattern of the portal vein. That's it. This is the effect of breathing, by the way. The breathing and the movement of your hand, the slipping from the jelly, can make the pattern disappear. But that is the monophasic pattern of the portal vein. Similar to the one I will show you on the next. Could you move the next slide, please? So if you look at the next slide, you will see the portal vein in the middle, which has monophasic pattern at the top, non-pulsatile, and you can have normally up to 30% pulsatility. 30%, and that is calculated by the fraction between the maximum velocity and the minimum velocity. So maximum minus minimum divided by maximum, that gives you the portal vein pulsatility index, which should be less than 30%. 30 to 50% is mild abnormality. More than 50% is severe abnormality. Do you see the column in the middle, the red one? Normal at the top, mild abnormality with some pulsatility in the middle. Do you see that one at the bottom? It is more than 100% pulsatility. The portal vein is almost reversing under the baseline, and that is severe abnormality of the portal vein. I would like to go back to the hepatic vein again, so as to show you something. So now you got the portal vein. If you tilt the tail of the probe up, that is the hepatic vein here. I will put color. I will confirm that it's the hepatic vein. I will put pulsed wave, and I will try to get, okay, so maybe you can slide anteriorly a bit in the abdomen and do a bit of tilting. A bit of tilting. Yes, you stay there. Very good. Just stay there. Okay, yeah, you see you're getting it. Just once you get it, keep it there. What I want to show you is you are getting the antegrade flow, but let's assume you got that triphasic pattern, the S and D. The triphasic pattern is explained by the movement of blood in the hepatic vein during systole and diastole. So when you have rising atrial pressure, you will have reduction of forward flow during systole. So the S wave will become smaller until at some point, what will happen to the S wave? It will reverse. And that's what you see at the bottom with a biphasic pattern and the systolic reversal of the hepatic vein. Why the portal vein is more specific than the hepatic vein? Because the hepatic vein is very close to the right atrium. The portal vein is far away, although they look anatomically close to each other, but physiologically they are distant, because there is a big network of sinusoids between the hepatic vein and portal vein, which buffers any pressure transmission from the right atrium to the portal vein. That's why hepatic vein will be affected by tricuspid regurgitation, but portal vein will not be affected. Whatever you see in the portal vein reflects the venous drainage of the gut. Okay, that's why it is the star of the systemic venous congestion assessment, and it is less affected by pitfalls. You might also encounter some healthy volunteers and athletes with no pathologies who have pulsatile portal vein. So keep in mind that they might have pulsatility without pathology, and that is explained probably by high cardiovascular reserve in these individuals. And it's a reminder for us to be cautious when interpreting any of the ultrasound parameters and use it within the clinical context. Is that okay? So finally, we'll go further down, slide downward until you see the kidney, and that is the kidney. Excellent. And then we put color, and then you get that pulsatility, or actually the color signal. So the kidney is the trickiest in the protocol because the flow in the renal vessels is a low flow. So you usually need a higher end machine to interpret the kidney, and you need to reduce the color scale down to 15 to 20 centimeter per second. The normal cardiac color scale is about 50. So that is important. This is something that is similar to the ventilator trigger. So you reduce the sensitivity and reduce the color scale to pick up the small velocities. And now you have the small velocities, and now you have to choose the right vessels. The right vessels should be the ones between the cortex and the medulla. You should avoid the hilar vessels in the middle. You should avoid the peripheral vessels, the arcuate. You should only trace the interlobar vessels, the one which are in the middle between the cortex and the medulla. So let's try to do that together. This is probably an interlobar vessel. And now you can see that we have a venous trace below the baseline. We don't have a consistent arterial trace above the baseline like what we see here, but normally you have an arterial trace above the baseline and a venous trace below the baseline. Arterial trace is not part of the protocol, but what you need to look at is the venous trace. Can you all see that? It is continuous and not interrupted, and that is normal. The normal venous trace should be continuous. If you see interruption of flow and stoppage of flow at some point, that's a sign of congestion. And the longer the interval of interruption of flow, the worse the congestion. So if you follow me with the image at the top, you will see at the top in the renal vein, below the baseline, that there is a continuous flow. And with mild congestion, you see the flow under the baseline in the middle, interrupted, but the period of interruption is minimal because you have systolic wave and diastolic wave. But the one at the bottom, you have clearly a longer interruption of flow during systole and only isolated diastolic wave. And that is the sign of severe congestion. So having done all these parameters, then you will have a combination of normal, mild abnormal, and severely abnormal. If you have any combination of normal and mild, that is mild grade 1 congestion, grade 1 VExUS. If you have one severely abnormal, that is grade 2 VExUS or moderate. And if you have two severely abnormal, that is severe or grade 3 VExUS. And that's the whole thing about it. Keep in mind that every one of these parameters has pitfalls. And that's why the validation with the study tried to bring the parameters together to increase the sensitivity and specificity of each of the parameters. Yes, of course. And so until now, the study looked at the incidence of acute kidney injury and the length of hospitalization, but they didn't look at mortality. So we don't have outcome-based data on VExUS score, but we have data on the link to acute kidney injury and the length of hospital stay. Yeah. Yes, indeed. Absolutely. And actually not only single pattern, the combination. So you get the score and then you have a baseline and then you do intervention, whether diuretics or hemofiltration, then repeat. And then you should see improvement in the pattern, which will be a good indicator of decongestion or deresuscitation. So you see VExUS 3 changing to VExUS 2 and then VExUS 1 and even VExUS 0. And always interpret that within the clinical picture, within the biochemical markers. I can tell you that I find this very useful in high dependence unit patients, because when they leave ITU, they are usually edematous, swollen, after all the fluids that we give them when they were in shock. And then they are usually with an acute kidney injury, with low sodium and high urea and creatinine. And if you find high VExUS score in these patients, you diurese and you repeat the assessment of VExUS. Then you should see improvement in the VExUS score with the offloading and decongestion. Of course.
There's only congestion. We see the same pattern that we can do the changes.
You're talking about obstruction. Yeah. Is that what you mean? In the kidney? Yeah, it is. So the pattern is a regional pattern, but putting all the parameters together indicates the systemic pattern. Because you are multi-organ. You are looking at the liver, the kidney, And also the whole thing also includes heart assessment and lung assessment. Yeah, absolutely. And it's a systemic venous congestion ultrasound using organ assessment. So you are assessing regionally multi-organs to get an impression of the systemic venous congestion. So give me example of isolated renal congestion. Yeah, but that will not cause congestion. That's different. If you have obstruction, the type of congestion is different. This is a venous congestion due to impairment of preload to the kidney, not urinary obstruction. That's a blood flow problem. Yeah. It's a good question because that is systemic venous congestion. That's right heart. The B lines is left heart. Yeah, so it's part of the whole picture. I do it all the time. When I do assessment, I look at the right heart, including this. I look at the left heart by echocardiography, B lines assessment, and cardiac ultrasound. But there's a good point about B lines. B lines appear late in the congestion cascade. So historically, we used to look at congestion by when you see B lines, you stop giving fluids, right? Did anyone do this? But that's a historical practice because we know now that if you have good diastolic function, seeing B lines is very late in the congestion cascade. You are likely to see abnormal systemic venous congestion much early before B lines. I'm not aware of amount of fluid. So I don't use B lines to quantify the amount of fluid. We use B lines semi-quantitatively to tell whether it's interstitial congestion or alveolar high congestion. But I'm not aware of any way to quantify how much amount of fluid by B lines, if that is the answer to your question. But we don't wait for B lines to decide for congestion because this is a left-sided congestion. The right heart gets compromised early, before the left heart, providing the patient does not have capillary leak in the lungs, does not have diastolic dysfunction. Okay? Any question? So each one of these pitfalls, each one of these parameters has pitfalls. We mentioned about tricuspid regurg. Did we mention about it? So tricuspid regurg will cause systolic reversal of the hepatic vein without necessarily having fluid overload, but it will not affect the portal vein. You can see portal vein pulsatility in healthy and young athletes without pathology. You can see IVC dilatation without congestion. Sometimes you see it in healthy and young volunteers, IVC dilatation without congestion. Of course, we see it all the time in mechanical ventilation. And you might ask me a question, is this validated in positive pressure ventilation or not? The answer is yes. The study had 50% of patients on mechanical ventilation and 50% of patients spontaneously breathing. And if you physiologically think of it, the parameters which will be affected by mechanical ventilation will be IVC and hepatic vein, in case tricuspid regurg will happen. But portal vein and renal vein will not be affected, because again, they are isolated from the pressure transmitted from the right heart. Liver cirrhosis, extensive fatty liver infiltration, lymphoma of the liver, it will cause blunting of all these parameters. So they will make it difficult to interpret them. And if you have a patient in cardiac arrest or peri-arrest with very low flow, you are unlikely to see waveforms as well. You will have stagnation of flow. Yeah, tamponade, if it's like a peri-arrest. But if you have early grade of tamponade with right heart increase pressures on the right side, you might see changes in the systemic venous side. Keep in mind that patients on ECMO There are no data on using this because if you have a venous drainage cannula in the right side, you cannot interpret the right-sided pressures reliably. But maybe you can think of it as a surrogate for right heart function. Because there is a question here. Some argue that any abnormality in VExUS indicate RV dysfunction. Do you agree or not agree? Any abnormality in VExUS indicates a degree of RV dysfunction. Do you think it's true or not true? Yes, that's a good point. So not necessarily failure, but a bit of dysfunction, because abnormal VExUS mean that the RV is not able to handle preload. That's why you have signs of congestion. So the concept is true physiologically, that dysfunction, but not necessarily failure, where you have high lactate, low cardiac output, etc. Yeah. So I think that's the whole idea about systemic venous congestion. We use it as part of a protocol which uses echocardiography, lung ultrasound, and systemic venous ultrasound. Using this multi-organ assessment, you are more likely to have better picture of patient fluid status and hemodynamics. Any question? Okay, so if then we can swap over and move to the next hands-on. Who's next? Who did the last time? I forgot. Both of you. Only you. So you didn't do. Are you sure? You should practice with your hand. Yeah. Why not? So if you don't have curvilinear, you can use the cardiac, no problem. And mid-axillary line, indicator to patient's head, 2D. And then, because you are on the lung, so you need to slide towards the feet of the patient until you see the liver. Maybe this is better. Yeah. So come down. The liver is here. Come down until you see more of the liver. Come down, down, down. Yeah, not that much. You see the kidney already. So up a bit. Slide anteriorly towards his. Very good. So which vein is that? Well done. Which one is that? Excellent. Very good. Very good image of the IVC and the hepatic vein. Can we put color on the hepatic vein? Oh, very nice. And if we put pulsed wave, I feel we will get a nice envelope. You probably moved, yes. Just bring it back again. Ah, fantastic. We got our, do you see A, the reversal, atrial contraction, asystole and diastole. And that is the one you see at the top. And that is the normal trace, biphasic, normal hepatic venous flow. Okay? Very good. And from the same point, yeah, you already, which vein is that? You already got it here. Tilt the tail down towards his feet, not up. And slide down towards his feet. A little bit, and tilt the tail up. Which one is this? And put color. If you are in doubt, it should be red. And then pulsed wave, and you got that monophasic continuous pattern of the normal portal venous flow. If you are in doubt about whether it's pulsatile or not, do the equation. Maximum velocity minus minimum divided by maximum multiplied by 100. That gives you percentage of the fraction.
30.
It should be less than 30. 30 to 50 is mild, more than 50 is severe. And then keep going down until you see the kidney. Keep going down, very good, stay there. And then I do a bit of tilting until you see more of the kidney, very good. Good to the image. And then color Doppler of the kidney. So in between the interlobar vessels, between the cortex and the medulla. Try to optimize it a bit, yeah? Try to optimize. You stay there. That's probably good. That's probably okay. Just leave it there. You got it. You got it. One of the challenges of the protocol is breathing. Patient breathing will cause the diaphragm to move, so the organs will move with it. So you have to be a bit patient. But you clearly see here the continuous renal vein, which is normal, uninterrupted. Seeing interruption of the flow of the renal vein is a sign of congestion. The longer the interruption, the worse the congestion. You don't see much of the artery, but you can see a bit of the artery here and a bit of the artery here. But the artery is not part of the protocol. The only thing the artery can help you in the protocol is acting as an internal ECG, because the arterial pulsation will be systole. So you can know when is systole, when is diastole. All right, well done. Who's next? The discontinuous, you have separate systole and diastole, S and D, with a short pause in between. But the D wave, you don't have S wave. You have a long pause, longer pause, and only D wave. Because the S wave is actually reversed above baseline. And it's hidden under the arterial wave. And that is the severest pattern of renal vein. Yes, D is diastolic, exactly. Please. Yeah, of course, you can use the cardiac. But you will find it difficult with the cardiac to see color Doppler pattern in the abdomen. That's one of the tricks, one of the pitfalls. Cardiac color Doppler in the abdomen is not good. But you have better pulsed wave Doppler signal with cardiac. Go here and then go there. And of course, when you use the cardiac, you will notice the image now is reversed. So you have the orientation marker to the right side. The patient head became toward your left-hand side and the feet toward the right side. Optimize the gain, the depth. Optimize the gain. And then let's see the IVC. You seem like you got the IVC here. A bit of tilting. When you do the tilt, keep it perpendicular like this. So then tilting the tail up. So can I show you? When you tilt, don't slide. So when you keep it here, tilting without sliding. So the tilting up, you're looking at the hepatic vein. Tilting down, you're looking at the portal vein. So which vein is this? It's tilting down a bit. Tilt the tail down. No, tilt the tail down. Which one is this? Yes. Color, you will see color, you will see nothing because it's a cardiac probe. But if you put pulsed wave, you will get a beautiful signal. Look at that. And actually, this was done with a cardiac probe. So you get the monophasic pattern of the portal vein. And from now you want to get the hepatic vein, you tilt the tail up slowly. That is the hepatic vein. So let's put the pulsed wave straight away. It's all antigrade, below baseline, but we are not getting the best hepatic vein. Try to optimize it again. Tilt that, yes, maybe here. Let's try again. And you're moving. Yeah. Yeah. So this is the one. So if I freeze, so you have the S and D, and all under the baseline. And then the kidney is difficult with a cardiac probe, I have to say. It's not that easy. It's easier because you have to have color for the kidney. You cannot just put the pulsed wave randomly in the kidney. You need to see the flashes of color. So if you put color, you see nothing. But what we can do is reduce the scale down, because it's 60 here, reduce it down to 15, but you still see nothing. So that's the challenge. The kidney is not easily performed with a cardiac probe. You need the curvilinear. But the good news is you don't necessarily need renal assessment, because you remember severe congestion, VExUS 3, you need 2 severely abnormal findings. So if you have severely abnormal hepatic vein, severely abnormal portal vein, you have the answer. And that's the case in ITU, because usually you want to know the extremes. Is it normal or severely abnormal? Okay, yeah. Very good. Who's next? Yes. Yeah. So there are two approaches. You can do subxiphoid, you mean? You can do subxiphoid, IVC, portal hepatic, but you cannot do renal. And portal can be also tricky subcostal. You can easily do hepatic and IVC. That's why I prefer, because either way I will have to move laterally to get the portal and the renal. And it will be the same, yeah. And both equally are good. And some patients, you don't have good views laterally. So you have to try and go anteriorly. When we say mid-axillary, I don't mean strictly mid-axillary. You have to be flexible. You have to move anteriorly. Sometimes it's best anterior axillary. Sometimes it's best closer to the midline. You have all around the liver to scan. Anyone else remaining? Did you all scan? Okay. Sure. Okay. Let's change the probe. So we have mid-axillary line, indicator towards the head. And maybe increase the gain slightly. So you're almost seeing the kidney, which means you're low that far down. So slide up towards his head. Very good. Now you see a good, which vein is that? Tilt. Yes, exactly. Tilt the tail down. Yes, that's the hepatic vein. And if you're in doubt, put color. It's beautifully the hepatic vein. And pulsed wave on it. Ah, there you go. You got the sweet spot of the hepatic vein. So that is identical to this. You have the A, S, and D, triphasic. Very good. You don't need ECG here. The A will go away, but S and D should remain the same. One of the main challenges of assessment of the hepatic vein is ectopics. Sometimes it's very difficult. If you have many ectopics, then you cannot tell what is S, what is D, even with ECG. Yes, very good point. So the V is a transition wave, which is the transition between S and D. Sometimes you see it reversed above baseline. And sometimes you see it as you see it here below baseline, but it is negligible. It has no significance. That's why the waveform is described as triphasic, A, S, and D. But the V is a transition wave. It becomes a bit tricky when you have reversal of the V wave at equal velocity to the A wave. Then you sometimes, without ECG, you cannot tell where is the A, where is the V. And that's another reason to need ECG. But like in here, you don't see the V wave reversed, so I don't need ECG. It's clear that this is A, S, and D. Like I'll give the example of the middle, the mildly abnormal hepatic vein. Do you see that? You don't see the ECG there, but you can see that there is reversal before the A and before the D. Do you see? There are small reversed. One above baseline, then S, and a small reversed above baseline, and then D. So one of them is A, and one of them is V. Because I had ECG, I knew that the first one is A, the second one is V. But without ECG, you cannot tell. Did I explain it properly? So try to have an ECG, which will help you in ambiguous situations. But this one is okay, it doesn't need an ECG. All right? And the next will be, again, back on the same, and then tilting the tail of the probe down towards the bed, the tail down towards the bed, not the tail. So maybe I can tell you a trick. Yes, it will be easier if you hold it like this. Try to hold it, yes, and hold it from here, so you have more, yes, exactly. And then when you, that's hepatic vein, tilting the tail down without rotation. You're sliding. So can I show you? So the tilt is moving the probe up and down. So tilting the tail down, I'm looking anteriorly to see the portal vein. Tilting up, I'm looking posteriorly to see the hepatic vein. So that is your portal vein. Do you see it? And if you put color, it is red. And even before putting pulse Doppler, you can see on color, the portal vein is non-pulsatile. Do you see any pulsatility? Is it flashing on and off or constant? So that is normal, constant. And when you put pulsed, you confirm that by seeing that constant monophasic pattern. Good. And we will finish by the kidney. Slide down towards his feet. And yeah, perfect. Very good. And then put color. And now you can see why the abdominal probe is better for the kidney. And then choose one of these peripheral vessels. It's a very good location. And that is a perfect location for renal assessment. Look at that. You got it. The artery above baseline, the vein below baseline. Well done. Who's next? Indicator towards the head, the patient head. No, the other indicator is the other one, is the ridge. So yeah, the liver. Which vein is that? Excellent. And color? Blue, pulsed. Marvelous. This is marvelous, right? Clearly, A, S, and D, triphasic. If you have severe abnormality, what will happen is you will see big one above and big one below, followed by big one above and big one below. It will be like a VT. The one above is diastole and systole, and the one below is diastole. And then going further down, you will tilt the tail down to get the portal vein. Tilt the tail down. That is the portal. Color, red. Its VExUS can be quick. You can do all in a couple of minutes. And that is your renal vein. Imagine at the bedside, you want to decide for fluid management, you want to decide whether to give fluids or diuretics, and you jump and do portal and hepatic vein. You can get the answer. Instead of blindly. If you want to give fluid to a patient and you go do the protocol and find portal vein 100% pulsatile, would you give fluids? Yes. I mean with others. I mean, if you have systolic reversal, 100% pulsatile portal vein, you should not give fluids. If it's grade 3, unless you have a strict hemodynamic monitoring, probably by PA catheter. And then go into the kidney, slide down and tilting the tail aside. That's it. That's it. Color. Fantastic. Which vessels to trace? So maybe this one is okay. Maybe this one is all right. Lovely. You get a nice artery. And even, I mean, we are practical. We work in ITU, so it's not the calmest environment. So if I see this, I'm happy because it's clear to me the renal vein is continuous. Do you agree? It's clear. It's not interrupted. Even it's not very clear. It's not very bright, but it is not interrupted. Good question. Yeah, so until now, there are early data on measuring that duration of interruption, the very early data from our nephrology colleagues to measure the duration of interruption, the no-flow period of the renal vein, and correlation with acute kidney injury. But the protocol itself kept it simple. If you have interruption, you have congestion. And if you have isolated separate S and D waves with a pause, this is mild congestion or mild abnormality. But if you have isolated D wave with no flow in systole, that's a longer pause. That means severe abnormality, like the one you see there on the screen. The one in the middle, you have isolated S and D waves with a very small period of interruption of flow in the middle. But the one at the bottom, you have a longer period of interruption, which is the period of systole. And you only have flow in diastole. I'm talking using the renal artery as my ECG, because that is the period of systole. Take the next one. It's clearer. Do you see the artery at the top? That is the systole, the beginning of the artery. Yes, this is beginning of systole. Do you see any flow in the renal vein? No flow. So the flow happens only in diastole. And that's severe abnormality in the renal vein. And that's why they have longer pause compared to the mild abnormality in the one above, where you have separate systole and diastole. So they describe it as discontinuous with S and D. Mild, discontinuous with isolated D, that is severe.
Directly measuring the renal artery.
That's a challenge because not only the renal, even the renal, the liver, any parenchymal abnormalities like extensive fibrosis, it will affect the pressures because these organs are capsulated. So that it will probably invalidate the assessment of congestion. But I think it will make it less sensitive. So you will not be able to rule out congestion if there is no pulsatility, but it will not change specificity. So if you see pulsatility with parenchymal abnormality, that is okay because you are still able to see congestion. We don't measure renal artery. We don't measure renal artery here. I don't understand your question. Hmm.
Directly from the renal artery.
For getting what? For congestion? No, yeah, but renal artery does not tell you about venous congestion. It's not part of venous assessment. Renal artery has separate assessment for resistance index. It's out of the protocol. I wouldn't go to that. I wouldn't go to that. And it's different and it's not part of the protocol. It's only renal vein. And I'm not doing much of renal artery assessment at the moment because it's not part of systemic venous assessment. Yeah. Any question? Did you all practice, guys? Any question about systemic venous ultrasound? Remember, if you have a patient with long-standing chronic pulmonary hypertension, you are likely to find abnormal VExUS, high score. But that does not tell you to aggressively offload the patient because their cardiac output is likely dependent on high preload. So if you aggressively offload them, they can crash. So be careful. Always look at the clinical picture. And we also already mentioned about the link between abnormal VExUS and right heart function. So that is something to keep in mind as well. If you have right heart failure, you are likely to have high VExUS score. And this could be used as a surrogate for right heart function. When you improve right heart function by diuretics, by inotropes, you will see improvement of the VExUS score, which is an indicator of improvement of right heart function. Yeah, I mean, generally, if it's causing right ventricular increase in the preload, you will have abnormality in the pattern the same way, provided the anatomy is the same. You know, congenital world is different, somehow can be different if you have abnormality in venous anatomy or any anomalies. But if there are no anomalies on the venous side, it should still reflect right ventricular preload in this population. And the same for LVAD. Patient on long-term LVAD, right heart function, the same VExUS could indicate right heart function, but this is not reliable in ECMO because you have a venous drainage cannula in the right atrium. So you cannot tell about right-sided pressures based on the parameters that you see here. Yes, yeah, because exactly, it tells you it's part, this is a right ventricular preload assessment. So afterload assessment by pulmonary vascular resistance, contractility, we know it, free wall and TAPSE, and this is preload. So with this, you have a bigger picture of the RV. All right, any question? Okay. Yeah, hopefully soon. Hopefully soon. Thank you very much. It was nice to meet you all. Thank you. All the best. Thank you.